Good morning, respected chairpersons, my guru, Dr. K. sir. I'm here to present the paper, my study on limb preservation surgery for failed femoral fracture fixation. Our aim was to establish the role of total femur and mega processes in limb salvage in cases of failed femoral fracture fixation and its complications. We would like to prove this with the cases encountered by us. First is a case of 71-year-old lady, diabetic, hypertensive, operated for bilateral total knee replacement in 2013. 3 years she was comfortable when she sustained a periprosthetic fracture which was operated elsewhere with a revision total knee and encerclage wiring. Post-operatively, she had another periprosthetic fracture at the tip of the proximal tip of the femoral stem, which was operated with open reduction internal fixation with a locking compression plate and encerclage wiring. Sequential X-ray showed the implant loosening, for which the plate was revised. Unfortunately, she sustained infection, and this is when she presented to us. She had a recurrent discharging sinuses from the thigh, and patient was advised hip disarticulation or amputation elsewhere. We operated her with debridement and implant removal. Intraoperatively, grossly infective bony tissues and non-salvageable femur was encountered. We had to remove the entire femur and replace with antibiotic impregnated cement prosthesis. On a later date, 4 months later, we operated her with total femur replacement with constrained total hip and total knee with mobile bearing tibia. 18 months today, patient is comfortable walking and acceptable scores. Another case, a 68-year-old lady with a history of road traffic accident and a comminuted distal femur fracture. Again operated elsewhere with distal femoral locking compression plate. She presented to us with a multiple discharging sinus from the right knee and implant failure, the distal part of the plate jetting out of the skin. X-ray was suggestive of broken implant in situ. The implant was removed and we inserted an antibiotic impregnated cement spacer. IV antibiotics were started. Waited for 4 months. MRI was not suggestive of any signs of infection. The blood investigations were normal, so the patient was taken for revision total knee. The frozen section biopsy was suggestive of infection intraoperatively. Hence, the TKR was postponed and antibiotic impregnated cement over a rod was reinserted. In August 16, we took the patient for the final stage TKR. Intraoperative frozen section was normal this time, hence we operated with LPS femur and mobile bearing tibia. 2 years today, the patient is walking comfortably with a stick support and acceptable scores. Another patient, a hypertensive Parkinsonian lady, sustained intertrochanteric fracture, operated with a proximal femoral nail elsewhere. 10 months from the surgery, she had an implant loosening and hence the custom-made bipolar prosthesis was revised. 8 months from the bipolar hemiarthroplasty, she sustained a periprosthetic fracture, which was operated with open reduction internal fixation with a locking compression plate and encerclage wiring. 6 months later, she had an implant loosening and had to be revised elsewhere. She also had an infection, hence the prostheses were taken out and are replaced with a cement prosthesis over a Steinman pin. 10 months from the surgery, she was operated with a constrained total hip. She was gradually mobilized. She was gradually mobilized and had a minor fall and sustained a periprosthetic fracture when she presented to us. We operated her with a total femur replacement through a dual approach, a medial parapatellar approach and a choice of extendable approach at the hip. 1 year down the line, she has acceptable scores and walking comfortably with a stick support. We operated all the patients with when they fulfilled the pre-op criteria of normal blood counts, ESR of less than 30, CRP of less than 10, a negative MRI scan, and ID specialist opinion was taken in all the patients. Post-operatively, all the patients had IV antibiotics for 2 weeks, oral antibiotics for 4 weeks, mobilized with walker support, and monthly monitoring of CBC, ESR, and CRP was done. A PET scan was done at 6 weeks in all the patients. So the difficulties and challenges encountered by us were the advanced age, gross bony and soft tissue fibrosis, chronic infection, higher incidence of complications owing to the blood loss and the fluid shifts, and demand of better outcomes, especially when compared to the pre-surgical status. So the take-home message is the total femur arthroplasty and mega processes serve to be a bailout procedures wherein in failed femoral fracture fixations, wherein antibiotics and debridement have failed to control the infection, and outcome was the gross bone lysis and destruction. However, it should be considered after all the treatment modalities have failed and the risk-benefit ratio should be thoroughly evaluated. Thank you.
Thank you, Omkar. Good presentation. Any questions from the audience? In your last case, you mentioned that you used custom-made hemiarthroplasty.
Sorry, sir?
You said custom-made?
In the first case, yes, sir.
The last case, I think.
Yes, sir, it was custom-made. Actually, we calculated the length of the femur on the basis of opposite femur. We did the CT scan of the opposite side of the femur, and then we calculated the length of the femur to be replaced.
That's for the total femur. But
yes,
you mentioned custom-made hemiarthroplasty.
Yes, sir.
For the last case.
Yes, sir. Sir, custom-made was for the bipolar hemiarthroplasty. It was operated elsewhere, sir, not with us. But yes, since she was a Parkinsonian lady, so they took out the proximal femoral nail and replaced it with the custom-made bipolar hemiarthroplasty.
Was total femoral replacement usually done by bone tumor team?
Yeah, right, sir.
Is it the same in your case? Or,
so we don't have a specialist for a bone tumor oncosurgeon in our hospital, but it was done by us itself.
Thank you.
Thank you, sir.
Very good. Thank you very much.
Thank you, sir.